What is risk stratification?
So, what is meant by risk stratification? Risk stratification refers to testing that we do, usually when a patient is first diagnosed with multiple myeloma, in order to help determine their overall prognosis and get some sense of the aggressiveness of their myeloma. And it usually entails both laboratory tests, often done in the blood, such as beta 2 microglobulin, lactate dehydrogenase or LDH, and albumin, as well as tests from the bone marrow biopsy called cytogenetics. These are looking for chromosome changes within the myeloma cells that can be predictive of the cell's behavior. We've known for some time now that the myeloma cells can have certain chromosome changes that can predict either for more aggressive or less aggressive behavior. And so based on all of those tests, we can come up with a risk status of the patient as either standard risk or high risk myeloma.
How is risk determined, and how does risk guide treatment?
So this is a very controversial area right now, and one where there's a lot of research going on. But there are certain abnormalities within the bone marrow chromosomes that lead to what we call higher risk disease. Higher likelihood that the disease either won't respond to standard treatments or will respond, but only for a short duration of time. And so we are sometimes able to use this risk stratification information to tailor the treatment to the patient. In some cases, this means we might use a different initial regimen, more aggressive therapy, or in some cases, we may recommend a different type of maintenance therapy, perhaps two different drugs used together rather than one drug if the patient has high-risk disease. In addition, there are a number of clinical trials now going on that are specifically focusing on patients who have some of the higher risk cytogenetics or higher risk laboratory abnormalities to try to see if we can change our interventions perhaps to get better outcomes in this group of patients. So that's how we're using the information right now.
More and more we are using cytogenetic data to really predict how an individual may do. But I want to emphasize the fact that it is truly a prediction or a prognostic tool. What I mean by that is when we look at all the factors, when somebody presents with myeloma, we look at clinical factors in terms of what the stage of their disease might be, what the symptoms they may be getting from their disease, what organ dysfunction they have from their disease. All those factors matter when we think about initial therapy and what benefit they may derive from that initial therapy. Cytogenetic profile has been used now as part of our staging system, mainly because when you group patients that have certain cytogenetic abnormalities and you look at outcomes, they do differ in terms of how well they might do, whether they have standard risk or high risk cytogenetics based on the mutational profile that they have in their bone marrow. However, we've all seen cases where that doesn't always hold true. So you have patients that conceivably have some of the higher risk cytogenetics that actually end up having a great response to therapy and a very long duration of remission. And conversely, we have patients that, at least on paper, look like they had very standard risk cytogenetics that end up having more refractory disease. So I always tell patients, it is very easy to just kind of fixate on one or two separate things and they kind of look at that as the end all be all. But I think, again, myeloma is very unique and you have to think about, you acknowledge those factors and sometimes you use them to make treatment decisions, but that also doesn't supersede what actually happens going forward. So when I meet with patients, they've had a great, let's say they have a 17p deletion, which is considered one of the higher risk myeloma cytogenetic abnormalities, but they've had a great response to therapy, whether that includes a stem cell transplant or not. We're all constantly faced with this question, well, that's what I was diagnosed with, but I'm doing well. I basically tell them that, it's not perfect system. We don't have all the information at this time. And we use some of these tools to guide patients and guide ourselves about what we might do for an individual, but that by no means is the end all be all for an individual patient.
So the risk stratification in myeloma is primarily driven by the presence of genetic abnormalities or the abnormalities found in the FISH testing. In addition, there are some laboratory variables, including the LDH as well as the ISS staging system, that also drives the outcome in these patients. So using all these ones, we can identify certain patients where the survival, both the progression-free survival and the overall survival, can be significantly shorter compared to the average patient. And these are the patients whom we refer to as high-risk multiple myeloma. roughly about 15 to 25% of the patients will be considered to have high-risk myeloma using the current stratification systems.